Terry today, who is on leave, but we do have Rachel. We should be without Sam, who's on leave, but I'm delighted that you're with us, Sam. But we also have Matt Holdaway and Ali Thornley dialing in. I think I can't see if they're here yet, so we won't be short of assistance from the nursing side. We have a couple of people who will dip out of the call because of other things. Tony Shapira has a configuration panel meeting, and David Wallaker a parliamentary committee with the Secretary of State. I wouldn't have sort of said yes to that if it meant leaving the whole meeting, but I just think at the moment it's very important that we're recognised as playing roles outside the trust. So I've agreed with those people dropping out at the key times for those our periods and coming back in offline. Very happy to have a discussion about whether that works for us, but I do think the more we're seen to be playing an effective role externally at the moment, I think the safer that is for us. I'm hoping that we might have Cecilia joining us as an observer sort of in the call, but the plan is, as you'll see, that we are recording this meeting, which I hope will be acceptable to everybody, given that it's a meeting that would be a public meeting generally, and that will enable us to make available the proceedings of the public board meeting in a recorded form as necessary. I think that's right, Neil. Have I got that intention right?
That's correct, yes.
Yeah. Good. I'm hoping that that's acceptable. So I'm doing the welcomes and apologies for the meeting. There's one, I think, new declaration of interest, Anne, that you wanted to mention, and Paula. So do you just want to let colleagues, or shall I tell them? Anne's been appointed to the council at the University of Swansea. Is that what I need to say, Anne?
Yeah.
Paula?
Yeah, I just need to formally put on record at the public meeting that I have joined the board of Michelmersh Brick Holdings PLC with effect from the middle of June, and that there are no conflicts of interest.
Thank you. Congratulations to both of you. Anybody else doing anything exciting that they need to put on the declaration? Claire?
I should probably just say I've just been appointed Senior Independent Director with National Nuclear Laboratory, but that is where I am already an NED. Thank
you. Congratulations to you too. Commiserations, I think, to all of you for what I'm sure will have its challenges as well as its interesting times. Are there any other declarations of interest on the public board that we need to get on the records?
Probably just my normal one about the charity, because I think it is referred to.
Thank you. Can I move us on then to the minutes of our May meeting? Katie's picked up a typographical error, which I think Neil will have corrected or be correcting. Are there any other issues that are not accurate in relation to the minutes of the meeting?
I had a point on page 10 of the papers. It's in the middle of the page where I didn't quite follow what was said. It says the Chief People Officer summarised workforce indicators. Sickness absence had been 3.5% at the end of March, including absences due to COVID. And then it says the figure for abscess related to COVID-19 had peaked at 7%, but it reduced rapidly down to 4%. So I was a bit confused by that. So,
could I propose that we ask Terry to clarify that when he's back from leave? Neil, would that be okay from you?
That's fine. Yes, yeah, I'll pick that up. Yeah,
because on the face of it, the 4% doesn't quite tally with the 3%, does it? So
yeah, I was a bit confused by that.
Yeah. Thank you. We'll get that clarified.
I should note there was one other typographical error which has been highlighted to me outside of the meeting, which I'll also pick up in.
Thank you. I'll also mention now, because I can see that Matt Akid has joined us, so that we can draft a board blog, which he can then put under my name and I can take some credit for. Very welcome, Matt. Anything else on the minutes? Okay, thank you.
Yeah,
On the
Sorry, it's Meghana.
Meghana.
Thank you. Just on page 11 of 13, fourth paragraph down about shimmy and HSMR, it says both indicators within expected limits. It's actually shimmy is within as expected and HSMR is below expected.
Thank you, and that's also true of today's, I think, if I've remembered
Yes,
correctly. Thank you, Meghana, and sorry not for seeing your hand until now when it's too late. So I think the only hands I can see were Anne's and Meghana's, both of which have now been dealt with. I'm then going to move on to the matters arising and review of the action log. On the action log, we mistranscribed the issue about the Horton maternity data, because actually we did deal with that last time, and the minutes show, and that should now be closed. The item on the HR and rotas is due to come in September, so that remains open. I think that means that we can propose to close the outstanding items for now and wait for the ones coming forward. But if I've got that wrong, I'm prepared to be corrected now. Anne, is your hand up again? Thank you. Anne.
I just wanted to query on the Culture and Leadership Programme, the second one, which we're proposing to close. I'm just obviously keen to ensure that that doesn't get lost. I'm not suggesting it will, but we're saying we're closing it because it's going to go into the cycle of business. But I'm keen to know when that might be, because I think that's a really positive initiative that we don't want to lose momentum on.
I agree with all of that. So I think that this is about moving to a business as usual cycle where it's core to what we're doing, as opposed to a project that might have been closed down. Rachel, I know this is Joe's bit, really, but I would have directed that question to Terry. And I think what we'd like to get a sense of is at what point would it be sensible for us to look at this again as a board? Do you happen to know that, Rachel?
I'd need to refer back to Terry on that, I think, and liaise with Joe Phillips. I'd just reiterate what you've said, that there's no question of it falling down the priority list. It's obviously remains important, and very happy to update at the right time.
Thank you. So would people prefer to keep that open one more meeting so that we don't close it until we've actually got that timeline? So I think that's, Neil, probably the preferred solution on that, because I don't think anyone disagrees with the basic strategy that this needs to get in the normal cycle, so it's regular business, not outside it. But we're worried we might lose sight of it. Claire.
Sorry, that was just going to be my point as well. I'm not sure we're at a stage to put it into regular cycle till we've had one more look. Okay.
Thank you very much. I think that makes sense to all the nods that I can see, and no one has talked against it, so we'll go with that, Neil. We haven't flagged up any other matters arising that aren't otherwise on the agenda. Has anyone spotted something that we should have done? Okay, thank you. If I can, I can't remember who was on the call when I said this previously, but I want to defer the patient perspective, patient experience video until we break for coffee, because we can't securely make it play on the Teams platform, but I'm sure you will all be able to make it play effectively on YouTube while you have a cup of coffee. So I'm going to aim for us to go through to the end of the IPR section on the agenda, and then have a slightly longer coffee break, and then pick up hopefully at around 11 o'clock as we would have planned with the rest of the business together. So that's early warning that you can plan your coffee machine or whatever at that stage. I have a limited amount of chairs business. I think principally I want to, as we've done previously, just record my thanks to everybody from Bruno down to, I don't know what the right thing down to is in relation to our staff, for the fantastic focus that people have showed and are continuing to show throughout COVID. I think, as we'll see as we go through, it's been immensely complex and everybody has had a role to play, and pretty much everybody's been asked to do something differently from what they were expecting to do, either as a task or in a way, and under a lot of pressure. So I'm really grateful for that, and I can't really say that enough times, so I'm going to say it again now. A couple of items of activity on my part that I just want to note on the record. I'm now attending the Health and Wellbeing Board rather than Bruno, and in addition to that, there is a new Oxford Senior Leaders Group which met for the first time last week and is bringing together the leaders of the councils together with the chairs of the two NHS trusts, and likely to include also some of the other emergency services to enable swift democratic support for the executives group that's having to get on with rapid response issues around resilience and emergency planning. The first thing it needed to do was to sign off the plans for responding to outbreaks. I'm very grateful to colleagues on the executive side for having made sure that was an easy thing for me to support on behalf of the trust. But I think that's part of the emerging governance structures around the integration of statutory services, democracy, the NHS around Oxfordshire, and there will be a similarly emerging pattern of activity for governing across the ICS, but we're not quite at the stage of knowing what that looks like outside of the executive aspects, where I know already the executives are playing a pretty full role, but I'm trying to tease out how non-executive side can also get supportive so that we don't find ourselves inadvertently placing our executive colleagues between a rock and a hard place by them needing to do one thing in one governance structure and thus not really understanding how that's happening. So I think that's work in progress at the ICS level and some good progress in Oxfordshire. And we will pick that up a little bit with the Council of Governors this afternoon when we talk about how the ICS is operating, because it's also an issue about how we engage with governors at that level. So those are the items of Chair's business that I had to report. I see no one jumping in to ask for more, although Claire still has a hand up, but I think that's the previous hand. And I'm going to pass over to Bruno for the Chief Executive's report. Bruno.
Thank you, Jonathan. I mean, the report is pretty extensive, so I'll just pick some of the highlights. And want to start with also again thanking all staff, but also students and volunteers and lots of other people who have been extremely busy and helpful to deal with the pandemic. Section 7 of the report highlights a few thank yous to people that are less visible, that are actually working behind the front lines. And we've been having a campaign to thank them as well. These are people, for example, that are working in the linen team, people that work in the clinical labs. So there's lots of people that are less visible, but have been playing a crucial role to provide an excellent service during the pandemic. We've also received a lot of thanks from patients for the great service that they received. And you mentioned that we'll look at one of the stories during this board meeting. But the story of Ken and Jenny are also in the report. They're also on the OUH website, and they're, I mean, pretty heartwarming to see how, thanks to excellent care, both Kenny and Jenny, after an extensive stay in intensive care. For Ken, it was 11 days. For Jenny, it was 13 days for Ken. It was 11 weeks for Jenny that they have been able to fight COVID-19 and survived the infection. So that's what we've been dealing with in the past couple of months. I also want to highlight the comprehensive staff testing that we've done. We're the first trust in the country that has tested all its staff members for both the infection, the PCR test, as well as the antibody development against a infection that they have dealt with. And the results have been pretty insightful. Meghana will take us through some of the conclusions and especially the actions that we've taken as a result of this staff testing. But certainly also again highlighted that some of our staff members are at higher risk, especially in acute medicine, because they're really at the front line. But also the BAME staff members are at high risk, and the porters and cleaners in our trust. And so we've been responding with infection prevention and control measures, but also, for example, for the BAME staff with risk assessments that are done on an individual basis to make sure that we protect them against the virus. The report also has an extensive update on some of the widely publicized clinical trials that the Trust is running with the university for a new vaccine, which has sort of potential global impact, but also the testing of existing drugs against, see if they work against the COVID-19 infection. And we've had, again, a breakthrough that a very cheap drug, dexamethasone, actually has a positive impact on the infection and reduces the complications, yeah, of that infection. I also want to highlight the extension of the emergency department. If you haven't been on site yet, John Radcliffe, it's ready. It's shiny on the outside, but it's even more exciting on the inside, with a lot more space, especially for resuscitation of adults and children, a new CT scanner, better access for the ambulance service. So it's a major improvement, both in terms of space, but also how we work within the emergency department. And it's very well received by staff and by patients. It's been a major investment that we were able to do because of our good financial performance in the previous fiscal year. You'll have, again, extensive reading on all of the awards and recognitions and great achievements that have occurred in the Trust or in the Oxford BRC, the Oxford Academic Health Sciences Network, and the Oxford Academic Health Partners, which was re-accredited before the pandemic, with lots of, I think, great achievements that I'm not going to go into detail, but I'm happy to take any questions on any of the detail or on the report as a whole.
Thank you very much, Bruno. I wonder, before I go to Katie, who's handed it out, if you could just say a little bit, really just for the record, about the amount of work you and colleagues are doing with the ICS, so that we as a board get a sense of the responsibilities you're carrying outside the organisation we don't have a direct sightline on.
Yeah, and we'll come in more detail on that topic. It's one of the agenda items in terms of the recovery. Okay. But also during the response itself, there's been a lot of work within the ICS to make sure that we have enough capacity in terms of critical care, but also ventilation capacity in general wards, mutual aid support in terms of PPE. We have daily calls with colleagues across the ICS to make sure that we have sufficient capacity for COVID-19, but that now has also focused on the recovery, and we'll give some more examples of how we're working together across the health and social care systems in the BOP ICS to make sure that patients that have been waiting now for a long time for an elective diagnostic or procedure, that we can try to get them that procedure as quickly as possible.
Thanks, Bruno. I asked that because I don't want the board to underestimate the calls on colleagues' time that come from working as a system. as well as internally to us. And I'm sure that the more that beds down, the more apparent it will come that the system working is the way of the future in terms of us moving forward. Katie.
Thanks, Chair. So, Bruno, there's some really great things, and it's lovely to have good news at the moment. So there's some really lovely things in your report. The moving medicine one is great, and I've been in touch with the team actually to find out a little bit more about what they're doing, because obviously it has a great interest to me. But I had a question about the emergency department extension. Do you think it's going to have an impact on the 4-hour wait target, or is it just about quality of care that's going to be improved?
Well, the 4-hour standard, certainly more space will help, but it's not going to be sufficient. So we need sufficient staffing in the A&E department, because it's not because you have more space that therefore patients are going to get seen quicker. So staffing still remains a concern, and I'll come back to that later in the board meeting. It's a key focus of attention for the trust management executive in terms of workforce planning. And certainly to deal with the winter pressures and potentially still a COVID-19 surge over the winter, that's going to be a real concern in terms of workforce, sufficient people working in the extended department. And then often we have breaches of the 4-hour standard because we don't have access to a bed when people need to be admitted to the hospital. So we are working again with the ICS to, as Jonathan was saying, very closely, but also with the regional team to submit some bids to the national team for expanding bed capacity, both general acute beds, but also critical care beds. And again, similarly to the A&E expansion, it's not because we have more beds that the problem is solved, because those beds also need staffing. So staffing remains, has not gone away. On the contrary, it has become more of an even more important issue to deal with.
All right, thank you very much.
Thank you, Katie. I think we're sort of flowing in, aren't we, in both my question and some extent that into the item on recovery, response and recovery. So perhaps I'll move us onto that. And Bruno, I think you're starting with that, but it may well be that you want to bring other colleagues in as well.
Yeah, again, it's a detailed report, and I assume people have read it. The recovery has sort of three main themes. One is the resuming of clinical activity and supporting staff to return to work. As you may know, some staff are still working from home or shielding. And we need to make sure that they can return back to work in a safe manner. So that's a key priority. Second focus on the recovery is to retain some new ways of working. That is, for example, the telephone triage, telemedicine consultations, which have been initiated as part of the response. We actually want to retain and even expand, and we'll have a bit more discussion on that. Also, during the response, we've been reshaping some of our services, especially pathways, trying to redesign how patients are seen, not just in a digital way, but potentially also different diagnostics and even different therapeutic modalities for certain patients that are safer for them and have the same outcome for patients. So it's sort of resuming, retaining, reshaping are the three themes of the recovery. The board paper itself focuses mostly on the resuming of clinical activity, with sort of a deep dive on cancer, radiology, pathology, and routine outpatient referrals. A sort of a common thread is that we're applying clinical priorities. So it's our clinicians that decide which patients should be treated first. And we apply that to all patients who are on a waiting list. That, of course, is against the backdrop that we, even during the height of the pandemic, we've been continuing with emergency treatments urgent elective treatments and, of course, deliveries of babies. That's been ongoing. When we say resuming clinical activity, it's more the routine and the non-urgent elective procedures that we're talking about. And for those, we're using clinical priorities, and the decision is a clinical-led decision. Cancer has been a good example. Even during the pandemic, we've been applying Thames Valley Cancer Alliance MDT meetings. It's another work of system working, not so much the BOP-ICS, but in this case, it's the Thames Valley Cancer Alliance, which covers the BOP-ICS, but also other STPs in the southeast, east of England, and southwest of England region. And all of those participating trusts joined into calls and agreed on priorities of patients that are on the waiting list of that entire region. So there's a single patient waiting list for cancer across Thames Valley, and it's clinicians in the trust, in Milton Keynes, in Great Western, Reading, Buckinghamshire, that are deciding on which cancer patients get access to which diagnostic and therapeutic modalities first. We're applying the same approach now also to the more routine electives with a focus on the BOP-ICS. And you'll see a limited number of specialties and challenged specialties where we have a large number of patients on the waiting list. And we're trying to find solutions within the ICS to make sure that those patients get access to the diagnostics and the therapeutics as quickly as possible. And we're also in discussions with the independent sector in the BOP-ICS, with Ramsay, Circle, the Nuffield, Spa Medica, Rutherford, a number of private providers, to see in areas for endoscopy, certain surgeries, radiotherapy, if we can use the private sector to make sure that those patients get access to either the diagnostic or the treatment. So that's all ongoing work, but I think on the positive side, most of our routine referrals are now up and running again.
Thank you very much, Bruno. I have a couple of questions, but I had Claire's hand went up first, so to Claire first.
Thank you, Chair. Bruno, I just wonder if you could say a little bit more about the drivers for the increasing 62-day wait for cancer.
Well, I'm happy to start, but then Sarah, I'm sure, will come in. So it's a combination of the fact that we have capacity bottlenecks. For example, endoscopy was a high-risk procedure during the pandemic and still is considered to be somewhat higher risk, although we now have lower infection rates in the community. And as a consequence, the pathways, we had bottlenecks, especially around diagnostics when it was invasive. And we also had more limited surgical capacity. And if people needed surgery, then there could be some more delays in that pathway. There's a second reason, which is that there's a lot of anxiety in the community still. And so even if we ask patients to come in, some of them prefer not to come in. So there's some patient choice in the delay as well. And what we have agreed in the Thames Valley Cancer Alliance is, because we're talking about a very big region here, cutting across the southeast, the southwest, and the east of England, and we want to make sure that we prioritize the resources for patients that would benefit most, in terms of outcomes from those resources. So it's a single patient list that we're dealing with, and we're trying to track if it's patient choice for the delay or if it's a bottleneck. And when it's a bottleneck, we're working with the Thames Valley Cancer Alliance and then the BOP-ICS as well as the STPs to create more endoscopy capacity or to create more surgical capacity, mostly in the independent sector. Sarah, do you want to add to that?
Sarah, off you go, and then I've got Anne after Sarah.
Yeah, so I can give a little bit more detail. So the number of patients that are over 62 days are 202, of which 84 are over 104 days. They are being reviewed by our clinical teams. So so they have had that clinical review by the particular MDTs that they're linked into. What I can say is 31 of those patients, particularly at over 104 days, are patients' choice, as Bruno's alluded to, because of their concerns about coming in because of the COVID-19. So 14 of those, that 84, are waiting for the bottlenecks around investigations, and that's due to the delays of the COVID. And 34 are being of the patients that are being risk stratified as part of the national guidance and part of that clinical priority, as Bruno's talked about earlier on. So I hope that gives you the level of detail that you wanted. But those patients are all being reviewed very regularly, and the harm reviews are being done for those patients waiting 104 days.
Thank you, Sarah. Just to understand, the people that are choosing not to come in, are we communicating with them about the sort of risk profile of that choice?
So we're communicating with them on a one-to-one basis, and also going back to GPs. So actually, do they want to still continue waiting on the cancer pathway? They can certainly wait on the 18-week pathway and go on to move on to that, or be re-referred. So when they feel, I'm making sure that they've got that proper support individually, and what other things can we help them to make that choice about coming in to be looked after and treated.
Thank you.
Thank you very much, Claire, Sarah and Bruno. I had Anne next and then Paula after Anne.
I guess
I've got Sarah after.
Okay, I think you've probably answered my question. I was concerned to ensure that obviously there's a long waiting list and that people didn't sort of drop off or slip through the net. And obviously part of that is people who don't want to come in because of COVID. And I was just wanted to be assured that, you know, we were continuing to communicate with them, because obviously that with time they'd feel more comfortable about coming in, and therefore to make sure that they didn't drop off the list because they'd opted at this point not to come in. So that it was really around that general question of how do we assure ourselves that we're not missing people that we ought to be picking up on.
So I also have a weekly assurance meeting, so we go through all of those numbers with the teams, but with the trust cancer lead, the divisional directors have all know about the numbers, and they're monitoring those as well on a weekly basis. So absolutely, very clearly monitoring these patients, making sure we're in contact with them is critical.
Thank you so much. Yeah.
Thank you, Paula.
To be fair, mine was a communication issue or question as well, really. I just wanted to be assured that we were communicating as well with those who are actually wanting to come in, are on a waiting list, because it must be really challenging for those. But I'm assuming the same processes are applying.
Yes, that's absolutely right, Paula.
Thank you. I did have Sarah Horden, but I can't see it now. Sarah, was your question answered?
Yes, it was. Thank you.
Thank you. Could I pick up a question that sort of follows on from that communication, because I get a good sense from the paper of the effort that's been put into doing this rationally and sensibly, although I might invite Tony Shapiro just to comment from a sort of clinician's perspective outside the system, whether it is as rational and sensible as it appears to me. What I'm less clear about, that's warning for Tony, I'm going to ask him next. What I'm less clear about is how effective we are about communicating the way we're going about this, both to patients, and we've picked up the individual level of patients, but we haven't talked a bit about how we communicate with the community, if you like, rather than individuals. But I'm also aware of a bit of noise from primary care networks and GPs, and I just wondered how effectively we think we are communicating this approach to the clinicians who are referring but haven't been party to these particular discussions. Bruno, were you coming in on that?
Shall I take that?
Yes, you take that, Magna.
Okay, so we are in close liaison and communication with Shelley Hales, who's the Director for Elective care. I think that's a title for Oxfordshire CCG, and discussions within the ICS as well. We have planned a WebEx with the primary care physicians and the team that Shelley would like to invite to the WebEx, myself, Sarah, and a couple of divisional directors, to set out the current status and our plans for this sort of longer waits, or even the communication platforms that we can have and create between clinicians and clinical leads and GPs. So that's what we are doing, Chair. And I know that there's been another WebEx with Thames Valley Cancer Alliance and the CCG.
Thank you. Sarah wanted to add something to that, I think.
So I was just particularly on cancer. So Shelley is actually part of the Thames Valley Cancer Alliance that meets very regularly, and they're actually in progress meeting now as clinicians. And again, we've been very closely linked into conversations with GPs, and as Megan has said, around WebEx with GPs, particularly on cancer.
That's helpful. I think that's something we want to pick up with the governors again this afternoon, because I think they're picking up a little bit of noise from GPs that they know, and briefing them on the system I think would be quite important.
So just to note, we have been open throughout the pandemic to 2-week wait referrals, and all urgent referrals and emergent referrals. We've not stopped, we've never closed at all. So so just be very clear about that.
I think this is about getting that message out there, because I imagine I'm not the only one who picks up a bit of noise that is easy to answer when you know the particular questions, but obviously hasn't reached people and creates unnecessary anxiety. Tony, am I reasonable in thinking this sounds okay from an external clinical perspective?
Yes, Jonathan, I think you are, and I certainly felt very reassured when I read the paper. I thought that this was a very good response, given all the practical difficulties. I think the prioritization is a key here, and I was reassured that the patient priority list was being operated across the system to try and ensure that patients had access appropriately and speedily. Of course, the management of that list will be quite a lot of work, and will require a lot of attention and inquiry to make sure that it's being operated possible, because the success of that is key here. Also, I'd add that the solution is very similar to those or that being applied in other parts of the country. I think most people are looking at the issue in a very similar way. But yes, I think I was reassured, and I think the board can be, that this is a very sensible approach given all the limitations.
Thanks very much, Tony. Before I move to Gavin, I think there's an accountability challenge for us in this, because if this were being done within just OUH, we would have a sense of where our responsibility sat for reassuring ourselves that harm reviews were being done, and that we were following our intentions. We might need to have a think about what is the appropriate governance for reassuring ourselves the system works the way it's intended to, and I don't feel I have a clear sightline on that yet. So perhaps we might take that into the ICS discussions about saying how will we provide assurance to ourselves, to our patients, and to our governors that this system is operating the way it's intended to. I think that would be a good thing for us to think about, because there's a definite risk of groupthink that could come out through this, and it could feel fine for the people close to it, but we need to find an appropriate challenge process into that. Gavin. Paula, have you made your comment? Your hand is still up. Gavin.
Yeah, thanks, Jonathan. It was just a very quick question about people who don't turn up to the outpatient appointments. Are we actually just following the standard protocol, which I don't know what it is, but it's sort of 2 strikes and you're out, or are we actually trying to reach through to people? I'm thinking particularly not just in cancer, I'm thinking right across the board.
So I think that we are following up with patients, but I think, Gavin, you're right, I think we can do more. So I have asked that we're checking about who hasn't turned up and I'm looking at that piece of work. I know that in some hospitals across nationally, they're looking at certain groups, and particularly vulnerable groups. So I have asked for that piece of work to be kicked off, just to look at, say, for example, homelessness patients that haven't turned up for DNA, so what's happening. So we're just doing that piece of work. So I think that's a valuable point.
Thank you. Are there any other comments or questions on the update on the response and recovery? So Bruno, perhaps you and I might pick up that accountability question and work out how best to talk about that with our colleagues. But I take it from that the board is assured by the care with which this is being taken, is particularly supportive, I think, of the clinically driven approach to prioritisation, and has noted a number of communications challenges, but that implies, I think, that we're confident we're trying to do the right thing, and we want to make sure that's maximised in terms of the efficiency of the processes and the clarity with which it comes across. I note that we will also have a chance to discuss this with the governors this afternoon, so it may well be that we get some additional insights from that discussion as well, which we will feed back to any of those board members who aren't going to be part of that afterwards. Can I then move us on to the infection prevention and control plan and the opportunity to discuss what we've learned from the asymptomatic staff testing? And I think, Megan, you're leading on this one.
Yes, thank you, Chair. So I will talk about the process in terms of what we did and when we did it, then the results, and then the actions which have already been implemented. So the testing proposal was approved on the 22nd of April, and the first clinic was on the 23rd of April. So this paper talks about the testing that was performed between 23rd of April and the end of May. As a background, by the 8th of June, 11,053 staff had signed up, and over 10,200 staff had been seen at least once. This is a voluntary COVID-19 testing program for staff using the nasopharyngeal PCR, which is the swab, and also immunoassay for IgG antibody. So 9,974 staff had at least one PCR result, and 9,405 staff had at least one serology result. So the total tests done by the 8th of June were 12,961 PCR and 9,687 serology testing. And since then, we've continued to see and offer about 150 to 200 staff testing every day. So in terms of the results, Bruno alluded to some of the highlights earlier in his report. So overall, in this paper, or for this data, 11% staff had evidence of COVID-19 at some point. We also asked them to provide data on potential risk factors for themselves. Staff with a confirmed household contact were at the greatest risk, with an odds ratio, adjusted odds ratio of 4.63. And as I mentioned before, higher rates of COVID-19 were seen on staff working in COVID-19 facing areas. So that's overall 21% versus 8% elsewhere. And in acute medicine, particularly, this was higher with an odds ratio of 1.5. And really, we're talking about late February, early March, when a lot of patients in acute medicine fit the profile of elderly patients who came in being off legs or with delirium and diarrhea, which weren't symptoms that were typical or described as typical symptoms of COVID-19. And in fact, they still aren't. But clearly, this is where learning comes from for ongoing care. There was also sporadic outbreaks in areas with few or no COVID-19 patients, which supports staff-to-staff transmission. COVID-19 intensive care unit staff were well protected, odds ratio of 0.46, and this is likely to be results of basically creating several conditions. So they were very heavily protected in type 2, level 2 PPE right from the start. There was almost a bundle around them for IPC. They had different working conditions. They took 2 hours on, 2 hours off, etc. And this clearly has been protective. So in response to all of these testing results, we have continued universal level 1 PPE for all patient contacts, unless where level 2 is indicated for AGPs in accordance with government and national guidelines. We triage all acute patients according to the symptoms of possible COVID or COVID and place them correctly. Currently, as of today, we have 5 patients in the organization with COVID, of which 4 are in the JR and 1 is at the NOC, and 1 of those is ventilated in ICU. We have established social distancing wherever feasible for all patients, and all visitors and outpatients are given a face mask should they arrive on site without a face covering. We have started a Ppe Safety Team, which includes members from the infection control team, us as executives, and several other nursing and medical colleagues who are visiting inpatient areas across all sites with the aim of supporting staff and answering questions about PPE and gently advising those who are seen to not wear masks or have any other standards that they're not following, and that's going really well. We are undertaking risk assessments for all our BAME staff, and that is being done now, going to be done on an electronic app, sort of app, as it were. And of course, social distancing is being reinforced at all times. We have tried to encourage clinical staff to take staggered breaks and also release areas within sort of administrative areas near the clinical areas, which can be used so that people are not huddled closely in smaller rooms. We've distributed hand sanitizer and Clinell wipes to all office areas. And we review constantly our cleaning procedures, and where possible, we continue to promote home working in line with government advice. So I'll stop there, and I'm happy to take questions, Chair.
Thanks, Meghna. Could I start just by asking for reassurance that we're going beyond staff we employ, so staff who are working on the site but not employed by us are also part of this process?
Yes, they are.
Thank you. I thought that was the case, but I just thought I would check. Other questions on the staff testing? Katie.
Thanks, Chair. You mentioned that there was going to be some discussion around the conclusions drawn around asymptomatic staff, and that's actually what my question was, around the conclusions one can draw from that, and whether perhaps you'd like to sort of expand on what you were going to say, because you're probably going to answer the question that I had. Whoever was going to talk about that.
So this is the asymptomatic staff testing program?
Yes. If you expand on that a little, it might answer my question. Thanks, Meghna.
Sorry, Katie, could you specify what it is that you're asking?
Well, okay. So the question I had then is, if contact tracing around asymptomatic staff did not lead to enhanced case identification, does this mean that it did for symptomatic staff, or conclusions may be drawn about how asymptomatic staff could be lower transmitters?
Okay, so essentially, whenever there was any member of asymptomatic staff who was shown to be positive, they were immediately asked to return, leave the hospital, return home, and self-isolate for 7 days. And of course, and also through occupational health, their contacts were then traced. And this did not reveal any enhanced case identification within the staff. And in terms of outbreaks, obviously, this is very important to control outbreaks and nosocomial infection. So we feel that once we'd done the contact testing of the asymptomatic staff who had been shown to be positive, it did not give us more concern that there was likelihood of spread within those staff who were tested within clinical areas.
Yeah, so is there a firm conclusion to be drawn from that?
I think the only learning we can get is that we need to continue and keep testing regularly all our staff as we move on. And although there is reduced community transmission, clearly as the social aspects open up, we still need to make sure that we socially distance at all times, wear masks at all times, and continue the testing. Because otherwise there is a risk of what has happened in Leicester to happen in more local scenarios.
So how frequently will we roll the programme through? How frequently will we test staff, Meghana?
So at the moment it is voluntary, and it remains voluntary, and people can turn up to the testing laboratory every 2 weeks. There is also, this protocol is very similar. Our protocol is very similar to the Siren study, which has been introduced recently. And the Director of Infection Prevention and Control, Katie Jeffrey, is in contact with the PI of the Siren study to see how we can collaborate with them in terms of the data and adding to the Siren study.
Thank you. So I think probably that is not so much board business as sort of general intelligence on what we can learn from not just our testing but others, and perhaps we'll think about that as a possible briefing item in due course. Gavin.
So one of the issues with the asymptomatic positives is that we know that the virus can remain in your throat for quite a long time, several weeks in fact, and it's probably not infectious. And we've looked at a couple of people and tried to grow the virus from them. So, I think one has to take the cautious route with this, which is they obviously need to go home and self-isolate, but it doesn't necessarily tell you they're infectious. And I think that comes to Katie's point, which is maybe, a number of these people actually had the illness a while before and are still carrying the virus, and that might be why they are not infecting as many contacts as you might expect.
Thank you.
That is the case, and we actually have data. But if we know a staff member has had several positive results, we know that exactly that person fits into your category. So we can make the distinction between a asymptomatic staff that tested positive, but probably it's because of the reason that the virus is still around but not active, versus an asymptomatic staff member that tests positive but has an active infection.
And what we've certainly maintained is that if at the end of that 7-day self-isolation period they remain asymptomatic, then they come back to work and only go back if they become symptomatic.
So I think we should avoid the board getting into that very interesting discussion about what we do and don't know. But I do think it's something as a board we need to get as part of our general intelligence. And of course, some people around the virtual table, it's bread and butter and they're doing that every working day, and the rest of us are sort of trying to glean from bits of briefing. So we might have a think about how we get a brief for the non-execs, particularly on what's emerging in terms of knowledge. Megan, I have your hand up. Is that a new hand or had I missed it before?
It's a new hand. Just to add that, so that we maintain, in order to maintain to offer testing, we obviously have to ensure that there is space and resource for this testing. Clearly, the medical students were a huge help up until now, but they now have returned to medical school. So it is, in terms of supporting the staff who are undertaking these tests, it's extremely important that we continue to provide the space and the resource.
Thank you. Jason.
I just thought I'd add on that, and I'll touch on this later in the IPR finance report, but at some point fairly soon, potentially in August, COVID costs will be run through the ICS, not the trust, and we'll have to effectively persuade the ICS to fund our COVID costs. So we may want a conversation pretty soon with the ICS about the scope of our testing regime, because the costs and resources that Megan was just alluding to will have to be funded by the ICS from probably August, and we may need to justify to the ICS if we're running a more extensive and more expensive testing program than other trusts in the ICS. We've obviously moved very fast because of our sort of unique position and partnership with the university, but actually, as things become a bit normal, we may need to justify the expenditure if we're an outlier.
Thank you. I think for today we note that, but it's flagged up to something we'll need to come back to. Can I move us on to the IPR now? So it's 10:10. I'm going to try and keep this down to 30 minutes so that we can watch the video over a cup of coffee and then not get too far behind. I'm not sure who's going first on the IPR. Is it Meghana?
Yes, I am, Chair. Thank you.
So, Meghana.
So I'm going to focus on the safety aspects and the IPC aspects in this report, and add a little bit more about QI generally. So in terms of safety, we saw in the last month's report that the number of reported incidents had dropped in March and April. I'm pleased to say that the number of incidents reported has now risen back in line to what it was pre-pandemic levels, which is good. We never stopped the patient safety response team. So although they didn't physically visit any area during this reported month, they did provide advice and look at all moderate and above incidents. There was an incident in May, which then was declared as a never event in June, which was a misselection of a drug, although the patient did not suffer an overdose. And I've spoken with the head of quality at the CCG, and we will undertake the investigation. And then if the investigation concludes that this is not a never event, then she is amenable to that discussion. The sepsis work has resumed during the pandemic. The sepsis nurses who are able to administer antibiotics in ED were moved to working in the ICU, and therefore there was a drop. I mean, that is one of the factors that led to a drop in our rate of administration of antibiotics within an hour to suspected red flag sepsis patients. However, I am confident that the teams are working very hard to get this back online. There is also some confusion about whether patients were COVID positive or septic, and therefore the data needs to be cleaned for this month. In terms of IPC, we don't yet have a trajectory for C. diff, which we have been given, but we have had 8 C. diff infections in May, and they're all being investigated, along with 3 MSSA and 1 MRSA. The MRSA has not been shown to be avoidable. And then finally, I just want to add that we had presentations from 5 individuals for a QI hub on Friday last week, which some of you will have attended, and Sir Jonathan certainly spoke at the beginning as a keynote, and it was very, very encouraging to see about 50 projects, even during the pandemic, which have been completed in terms of quality improvement. And some very notable projects involving patients, both patients and relevant stakeholders, to improve the quality of care we offer in the Trust. And I'll stop there.
Thanks very much, Meghana. Any particular issues on Meghana's part? I was going to ask about sepsis, but she's answered that bit, so that's great. In which case, who's next?
Chairman, it's me, it's Sam.
Thanks, Sam.
So just before I start, I just wanted to thank Mark Curry and Eileen's team for ongoing support to shape this document. And there's quite a large discussion plan for TME tomorrow. Mark's done some more work into the performance management and accountability framework, and we continue to aim to present this at service level going forward, so you will see less siloed approach. In the meantime, today I'm going to just briefly touch on 3 areas: our overall care indicators, maternity as the dashboard's now fully integrated into this report, and then urgent care before handing over to Sarah. So overall, with our care indicators, at Integrated Assurance Committee last month, we talked about a deep dive into frailty. I think Meghana and I would like to just seek a little bit more advice about how the scope of that piece, but we are certainly looking particularly around pressure ulcers and falls. In terms of falls, we have seen an increase significantly. Actually, the patients haven't suffered any harm. And I think that some of that in part is due to us not having visitors for this period. So that will be interesting to keep our eyes on as visitors start to come back into the ward areas. From a pressure ulcer perspective, the two areas that we're really focusing on at the moment is skin damage to staff through prolonged use of PPE, and also a piece of work with the Shelford Group around skin damage from proning. And Matt's on the line, and we can certainly expand on that about the significant amount of hours that patients were prone ventilated during this period of time. Rachel will pick up on nurse staffing in totality across the workforce side, but the significant impact around the international pipeline is now being felt. We have over 200 nurses in India waiting to come across and join us. So we're really starting, whilst the retention is held steady, we are starting to feel the impact of that planned pipeline. Just moving on to maternity, the two areas to pick up on are the midwife to birth ratio is slightly increased due to increase in births in month, and a review around any potential variation around 3rd and 4th degree tears is being reviewed by the service. We're in a good perspective around midwifery staffing at the moment, in fact slightly over recruited as we're expecting a retirement. I can pause there and carry on with urgent care.
Could I just ask Sam just one question on the maternity bit of the dashboard? Did I understand it right that you've identified that the tears issue is probably related to an individual or a couple of individuals' practice, which can then be sorted out by working with them? Is that the right interpretation?
No, it is. I think it's always difficult when it's a percentage. So what I would have done if I'd have had time is clarify that number. But I think it's definitely indicating that it's some support that's required for one or two individuals. So that really
is a very small number because that appears in the appendix, and it's distorted as a percentage because it looks to be at the Horton. But I think if I've understood right, that's in hand as a sort of staff development support issue, absolutely. And that hopefully will work it through. Thank you. Claire, did you have a comment on this question on this bit?
Yeah, I just wanted to ask about falls. I noticed they'd increased, but I wondered sort of if it was good news or bad news in the sense if you compared it to the number of inpatients we had at any one time, because of course that must have fluctuated during the COVID crisis.
Well, our occupancy was at its lowest, Claire, so it's probably not good news. I believe that it's due to less people around in the bays. It's one of the things that you see when you introduce open visiting. There are more people around to supervise and flag if there aren't people in the bays. So I think the good news is that there's no harm to patients, but I can't correlate that to an increased total number of patients.
Sure, and I think maybe there might be some learning if we're unfortunate enough to have a second wave of COVID and we sort of go back to that situation. Is there anything that we can do to help mitigate that?
Yeah, we're looking at that at the moment.
Thank you very much, both. Sam, do you want to move on to the urgent care?
Yep, for urgent care, for May, our 4-hour performance, I'm just looking what Katie said, better than, better, improvement on both nationally and in our Shelford peers, and our occupancy is now starting to rise with around an 89% occupancy. In terms of flow, we're ahead of trajectory of less than 90 patients of over 21 days. And as Bruno mentioned earlier, that's a continued daily focus across the system with colleagues, particularly from Oxfordshire County Council. And in addition to that, the system focus of the more scale rollout of discharge to assess. And we're just working with the ambulance service now to prepare. Colleagues will have heard probably on the national media, the 111 pilot. There's great concern around congestion in the emergency departments as winter comes. So there's a pilot at the moment being run in Portsmouth around looking at how we can triage patients before they come into the emergency department via increased use of 111. So I can report back on that after A&E delivery board next time. Again, I think the fragility of staff run through all of our constraints to delivery, and the 2 or 3 pieces of work just to feed back on to make further improvements. We're working with directors of strategy across the patch to develop an Oxfordshire urgent and emergency care strategy that will form into the Bob workforce piece. We're also at the moment putting together a bid for NHS Charities Together, who've asked for a specific theme around system working and supporting recovery through COVID. So that's something that we should have drafted by the end of this week to share with our charities for support. And then I think I would just like to note that there is some specific improvements around A&E department that you'll see later on in the report, where we appear in the top 20% better than last year around how much information you were given around your conditional treatment in the emergency department. So I think that's certainly worth a mention.
Definitely is, Sam. It's ticked off my list. I was going to observe that for later on. Paula.
Hi, thank you, Sam. And it's good to see that our 4-hour performance is improving and that the relative performance is improving, or is better than. But we do have this ongoing issue. We talked about it a bit at the beginning about having the right staff in the right places in order to try and get the breaches down for those who are arriving late in the evenings. Can you say a bit more about what we're doing? Because we have been on this topic now for a while. It'd be quite nice to know, if we have some milestones of what we're trying to achieve and how we think it's going to have an impact on those particular breaches.
So I think there's two things, and I'm sure Sarah will come in. One of them focuses on the workforce plan, and workforce is certainly a constraint, and we're not able to fill all of those shifts. And the second piece, which has been identified by the division, is the specialty delays. So discussion at Trust Management Executive to exercise the emergency department consultants' admission rights, which again is something that we've talked about before, but is a significant behavioural change.
Yeah, I raise it because it was absolutely part of the improvement plan that we worked so hard on, and it just feels like the piece that we're not. And I can see that it's been made more challenging because of the last few months. But it feels like it needs real focus. Sorry, I'm confident it's getting real focus, but I'm not sure that I see specific actions coming through that we can monitor, because
it looked as though Sarah wanted to come in on that. Sarah.
So just with the COVID pandemic, we did quite a number of moves around the JR2 stack and our flows around the specialties. So we're in the process of reorganising the JR2 stack so that we get into making sure that we've got clear sort of lines of surgical, medical floors, and so we're just in the middle of doing that. So and regrouping of not quite where we were before, and it's that reshaping of what we need going into this winter, and looking at potential surge and our winter preparedness. So that hasn't particularly helped, I think. But I think as that settles, I think we need to have that focus.
It'd be great if we could get an update, perhaps when you've completed that work, so that we are clear what the proposals are and what the KPIs are. We can watch to see that improve, so it just doesn't become the running comment. I recognise the work that's going on completely.
I see nods from Sarah. I think that's heard. Sam.
I think that just Larry, with his background as an emergency department consultant and now as our divisional director with an occupancy less than 92%, we have encouraged him to exercise that admission privilege, if that's the right word for it. And certainly that was Meghana's message at TME last week. So I shall make a note to feed back to him.
Thank you.
Thank you. Who's next? Is it Sarah? You next?
So conscious we have the previous paper, so I just wanted to highlight things that perhaps haven't come out through that paper. So just looking to the waiting list, our waiting list is made up of both outpatients, patients waiting diagnostics, and those patients waiting for treatments. So as for about the third consecutive month, we're now seeing a reduction in our total waiting list size. That's in part due to the referrals, some of the routine referrals not being switched back on. But as we heard earlier on, that we are doing that. But also we've kept doing a lot of validation of our waiting list throughout this time. So we'll be actively doing that piece of work in the background. So that's been really, really important. So just on terms of our 52-week breaches we see for in May, they have climbed up to 499, and that's mainly because we have not been doing our elective work. And as you can see on the right-hand table, those key specialties, those challenged specialties, as we talked through in the previous paper, that are most challenged, mainly high volume, specialties, but also specialties where our first outpatient waiting times at polling ranges are really long, as shown in the previous paper. So that those are of concern. We are in the middle of risk stratifying the total waiting list, so into 4 categories. So category 1, most urgent, that need to be treated, and those become the emergencies, the urgents, and the cancer patients. Category 2, category 3, and category 4. So we're doing that, and as you can tell, even that we have reduced the waiting list. That's a lot of patients. We've also revised our harm review process. You know that, or very aware that we're doing the 52-week harm review process at TME on the 25th of June. That's been dropped down to patients at 40 weeks. So all patients are reviewed at 40 weeks to determine an appropriate course of action. So that, and if they've had a moderate harm, that's triggered, and that will go to the patient safety response team. So we have revised that, and that was agreed at the RTME. So really making sure that we're looking and highlighting any patients of concern or of harm. The patients on the waiting list, or those patients over 52 weeks, because we haven't treated them, go over to those patients in June. So we added to the patients in June. So at the moment, our potential number of 52 weekers in June will be around 959, although we're still validating that, and we haven't shut that month down yet. So those are, though it is rising. So that's why it's really important that we're working with Bob and ICS colleagues, looking at how we can work with them in making sure those patients are treated in a timely way, and looking at alternative provision of our independent sector, things that Bruno talked about earlier on. So really a lot of work is being done around those particular specialties. If I may, on diagnostics, the number of routine diagnostics were up to about 10,000, which we hadn't treated. That's now coming down below now 2,000 patients. So really getting on top of those diagnostics, which is really important. So that's really good. And in terms of our cancer patients, we talked about the long waiters, but I just particularly, although we have improved our performance for April and we're always 2 months behind, just a caution of note that we do have those 202 patients over 62 days which that haven't been treated, so therefore do not form part of the standard. So when we do treat those patients, our performance will drop, and it's just a reminder of colleagues that will happen. So those are sitting in the background. That's why it's so important to really make sure that colleagues are aware that we still have that amount of patients waiting, which I won't go into earlier on. What we have seen, which is really promising, on our 2-week wait referrals, we're now receiving around 470 a week. So which has really come up to where we were pre-COVID, which is really encouraging. So patients are returning back to us, and through GP referrals, which is really good. We can see that our waiting list for cancer has also increased, and we can see an increase particularly in our breast tumour sites, lower GI, lower gastroenterology, urology, and gynae. So those are increasing, particularly in lower GI or lower GI. It's the endoscopy, which we talked about earlier on, it has been the bottleneck. Therefore, we are looking at increasing that capacity, both within Oxfordshire, we're working with our local commissioners, and of course across the Bob, and working across Thames Valley colleagues. I'm going to leave it there, Chair, and ask colleagues for any questions.
Thanks very much, Sarah. I mean, I think I'll just note, as we change to a shared waiting list, we'll need an equivalent metric or graph to give us a sense of how we monitor whether it's working as we expect it to, and it may make what we have less insightful. So we made that point earlier. We've heard a lot earlier about what's being done about the waiting list. Is there any other issues for Sarah at this point? Okay.
Just one, actually. I was sitting here reflecting on how much work is going on that Sarah was describing so well to try and get the 52-week wait list under control after all the effort we put in before. So I'm really conscious of that work. I think to try and understand it better, it would be really good if we could make sure, as we monitor progress, we see though we split out those that are going onto the list, some data from those that are coming off the list, so we can watch what's coming off the list, because if we net it all off, we're not going to have much sight of our ability to get it down, because the point Sarah made, which was so compelling, was the scale of the increase that's likely to go on month to month. And I quite like to be able to find a way of looking at the pluses and the minuses in a high level to see that there is some change.
So our normal elective activity usually takes off around 500 patients a month. So that would really support the patients moving into 52 weeks. So that's why that's increasing. So, but certainly the number of GP referrals coming in, we can certainly produce that for next time, Paula. That's
something that enables us to see a little bit of two ways.
Thanks. We'll take that away and see what we can do. Tony.
Thank you, Jonathan. I was just wondering how many of these clinical performance parameters that we've been discussing could be compared with our peer group, so as to give us an external perspective of how well things are going or otherwise.
So many of the quality indicators can be benchmarked across the Shelford group. The question, certainly in my mind, always is whether that would be right to be presented in a public board papers without knowledge of those other organizations.
Yep, I can understand that, but it might be helpful for us just to have that at some point in some venue, so we can see how we're doing more generally.
Certainly, I've got that for cancer, Tony, so I can certainly put that, but where we are with the Shelford group and also where we are nationally, I can also do that with RTT as well. And I can send that around as part of after this meeting, if that's helpful.
So I think, Sarah, let's do that as a briefing to board members as a result of this, not as a formal part of the board papers, which then avoids us needing to check out what can and can't be public. When we've had that briefing, we could have a discussion about whether it would be useful to get it into the regular reporting in some way, even if it's just a benchmark line on some of the graphs. Thanks, Tony.
Thank you, Chair.
I think that takes us to Rachel.
Thank you, Chair.
You can assume you've read the papers. You don't need to talk to everything, just to
Thank you. I'll briefly summarise our position in terms of KPIs then and our key actions, and then I'll pick up some additional actions in terms of our COVID response and how we're supporting staff to cover off anything not mentioned already. So our sickness absence rate is 3.8%. We're clearly seeing the effects of the pandemic on the workforce pulling through into that rolling absence figure. When we exclude that, which we can do through our analysis, that comes down to 3.3%. So there's a very clear effect of COVID, although COVID-related absence has fallen considerably now to quite a low level. We are also seeing an increase in absence due to stress and anxiety. And I'll talk a little bit more about the interventions that we've got in place around that, but that's clearly a trend that we need to monitor and keep under review. Our vacancy rate is looking quite good, but as we've already heard from Sam, we've got particular risks around that we're keeping under very close review. And primarily that includes the overseas nursing pipeline. So we're working very closely with Sam's team and getting the latest information about when the OSCE centres may reopen, keeping in touch with our pipeline overseas in India, and making sure that we've got plans in place to support them if and when they do arrive back. So, for instance, how we would support them through a period of quarantine. Our turnover, again, has come down in terms of trend, but we're very mindful that there's probably a pandemic effect in that, with fewer people moving around in the labour market. So again, we're very conscious of any hotspots we've got. And I think in terms of maintaining our focus on that, again, it's very important for us, and we're devoting a big focus to supporting staff, engaging with staff, and ensuring that they are supported in terms of their health and well-being to support their retention. We've seen a very small reduction in temporary staffing spend overall. The Trust Management Executive agreed a range of new interventions in May, which haven't yet worked their way through into the data, but they include higher levels of scrutiny for the sign-off of temporary staffing and some changes to the way the rostering system is managed. We have some, in terms of appraisals and statutory and mandatory training, we are out with our targets there. So we're still seeing the effects of the disruption to business as usual, although the HR teams are working closely with the staff lists that they have available to encourage staff to have their appraisals done and to keep up with their statutory and mandatory training. In addition to that, the Director of Culture and Leadership is leading a deep dive into some of the more historic issues that we may have in these areas. So to look at the effectiveness of our systems and our data recording, to identify some interventions that we can put in place to improve those rates further. And just in terms of our COVID response, we continue to support staff who are absent due to COVID through daily wellbeing checks and to see what support we can put in place for them. We're also mindful now we're going to have a group of staff coming back from shielding. So by the 1st of August, we'll have plans and support in place for those staff to enable them to return to work where that's appropriate, or to support them to continue working at home where that's appropriate. We're also mindful about changing government guidance and supporting communications to staff, both through clear corporate communications and local communications through the HR teams. And we've heard about some of the support we're providing for our BAME staff. We're also working very closely with the BAME network on that to ensure that we're engaging effectively with that group of staff, in touch with what they are saying and able to respond in any way that we can. And I'll pause there.
Thank you very much, Rachel. Anne, you had your hand up.
Hi, yes, it was just a question on the bank and agency staff in numbers. I notice on page 42 of the pack, or no, page 87 of the pack, that we've got a very high number of corporate staff in bank and agency, and I couldn't immediately get my mind around why that would be. It's much higher than in any of the categories you're showing on that table.
So I can tell you that's a particular area of focus, and that's where we're implementing some additional controls to look at that.
Is there one particular area within corporate, or is it spread across the whole of the corporate divisions? Jason may be wanting to answer. I see he's got his hand up.
Jason, is that the reason you have your hand up?
Only to say that I think probably will give you all a written answer there. That may be a misallocation. I will just cross-reference it to the data I see. There is a pocket of agency staffing that's been approved in IM&T for a small number of projects where it's been hard to recruit. That's but I'm not sure I entirely recognise the 300 in corporate on the bank. So let me work with Rachel to check that out.
So Jason, you'll brief us by email, and then we can just note next time that that briefing went round, unless something particular is flagged up, in which case we can work out getting it on the agenda. Did you have your hand up for another reason as well?
No, Chair.
Okay. So Sam.
I think Jason's right. There's been quite a bit of coding. So lots of the student nurses went onto my corporate cost code, for example. So during COVID, lots of the kind of additional people that work bank, etc., just got put onto our cost code to sort out later on, and so that we could track them. So it's likely to be the large group of student nurses. But as Jason said, we'll come back with clarity if that's not correct.
Thank you very much. And did your hand go back up again for another question?
Oh, no, sorry. No.
I think what happened was I put your hand down while you were speaking, and then you thought you were putting it down and went back up again. I'll be more disciplined, so I won't put your hand down now, Sam. And so if you want it to go down, you can put yours down yourself. Thank you. Okay, I think then, thanks very much, Rachel. That takes us on to the financial section. Jason, I'm going to hope that we get through this in 10 minutes and then give people a chance to have a break and watch the video. Is that realistic?
I hope so, Chair. I won't speak for more than a small fraction of 10 minutes.
Great. So the challenge is to everybody else to be very focused, as Jason is. Jason.
So I'll just pull out a few highlights, Chair, as you've reminded us all that we should take the paper as read. Clearly, under the COVID financial regime, we're reporting break even. I would be remiss if I didn't highlight what the paper says in several places, that if we were on the pre-COVID financial regime of payment by results, but doing our current reduced levels of activity, we would instantly be dependent on external support for our finances. Now, that's a slightly artificial way of looking at things, but nevertheless, it is essential to remind ourselves of that. We discussed it extensively actually during the year-end process because it was very material to where the accounts were drawn up. We have incurred COVID costs of £16 million year to date. As the board will remember, hopefully from the May board meeting, we didn't attempt to budget for COVID costs, so that appears as part of a variance to the overall budget. We're actually doing slightly better than the NHS England assumptions about non-COVID costs or non-COVID income, which is good. There are a few short-term actions that the paper highlights that we're taking in respect to the current run rate. So we're looking at the continued use of temporary staffing beyond COVID use. You can see in the paper that the reduction in temporary staffing is less than the reduction in activity. So whereas our non-pay variable costs are beginning to fall in line with the reduction in activity, our pay variable costs aren't. And I think that is potentially a concern, particularly as we come out of COVID. We're also looking at the rate of COVID non-pay spend. We spent very heavily on PPE in April and May to build up a stockpile. Now, typically we expense our stock at the moment actually in year and true up the stock count at the year end. So we haven't used all that amount of PPE. We now have 2 warehouses full of PPE. And because that buffer's been built up, I'm looking very carefully at the forward order book for COVID non-pay, i.e. PPE, to make sure that we don't accidentally fill up a third warehouse. I think we probably have, as best we can tell, given the sort of current supply arrangements, I think we now have a substantial buffer. The execs continue to get a daily report on PPE stock levels, both in terms of the absolute level, but also the number of days stock we hold based on a rolling average of recent consumption. So we're confident that, with the exception of 1 or 2 areas, we have a very healthy buffer. The 1 or 2 areas where we're continuing to do direct sourcing are wipes and hand gel, where obviously as we reopen for non-COVID work, volumes are increasing. And the national supply chain deliveries are a bit restricted, so we've recently placed some quite large direct orders ourselves to secure enough wipes and hand gel. And the other short-term action we're taking is just looking at the IT capital spend, which is running at a higher rate for the first 2 months than the budget for the year. So we're looking very closely at the number of essentially open approved capital order codes that IT can book to make sure that they aren't continuing to spend against sort of underspends from previous years, which David and I are working on. Looking forward, we're preparing for the post-COVID financial regime. Now, at one point we expected we might get an announcement about that on Friday, and we might still, but equally, it's very uncertain. You'll have seen the sort of press speculation as to whether the NHS nationally and the Treasury have sort of concluded on the big picture of that, and we won't get details on our share. But the indications of what that might look like are set out in the executive summary. And I've taken the execs through this in several stages in the last few weeks. We anticipate a tougher financial regime for the remainder of the year, which continues to have block contracts, but probably is a fixed cash envelope rather than effectively an automatic top up to break even. And that will require a degree of adjustment and tougher control both to hit whatever our financial target is, let's say break even as a minimum, but also potentially to give us a buffer if we think that some of our COVID costs or recovery costs are sort of not fully funded nationally. We actually are beginning to discuss how we might create some headroom in our current spending so that we can locally fund what we need to fund. And I will stop there, Chair, and take questions for as long as you permit.
Thanks very much, Jason. I think we will need a rapid board briefing on the new financial regime as soon as it's announced, because you may understand it, but the rest of us will take a bit of help on that. So I think we should just note that as soon as we can, we'll need to arrange some form of briefing call on that. And I have Anne and then Paula.
Okay, thank you very much. Thanks, Jason. Just a couple of points. One is a bit of just a note, really, and that's the IT spend. The fact that you flagged that seems to be running at a high level. It's really just to refer back to that has been typically an area where we haven't felt that it was totally under control. And I have every confidence that David's now dealing with that. But I just really wanted to flag that has been an issue in the past, and it is a concern, obviously, that it's showing at that level now. So that was the first point. And the second point, I noticed that the cash variance has been highlighted in the report, and you're doing some more work on that. Be very keen to see the outcome of that work, because obviously that's another big concern about the financial sustainability and the short-term performance of the organisation. If we run out of cash, it's going to cause quite a lot of concern. So there's my 2 points.
Chair, if I may, I won't respond to the second one because I think Anne was just expressing sort of interest in a bit of work that's underway. On the first one, it's worth noting that the concern that we've discussed in the last 2 years have been about overspend on the revenue budget for IT, and this is a slightly different manifestation of the issue. I think the underlying causes are some of the control issues that we actually discussed at the February Audit Committee, but there is a more precise mechanism here, which is how many open capital budget codes do IT have, and if a project has come in perhaps under budget, do they essentially try to spend that underspend on something else? So what we're looking to do is slightly more forensically control the IT capital codes.
Thank you, Paula.
I think as we're going through into this year, two of the areas that we know we had to control so very closely, and it's going to be even more so given what you said about the likely way the regime may change. One was IT, and Anne just dealt with that. But the other was our pay costs and pay costs with activity. And you made the point a little bit back that actually the pay costs are not coming down with activity in the way we would like. A couple of meetings ago, or maybe it's only one public meeting ago, we talked about the new controls that Terry had said he had implemented. So I just would like to understand whether those controls are actually operational to try and put much better gateways in to control this area, because if we are sitting here in July and if we are not making progress on those controls, then presumably we need to do something to improve them.
Sure. So the first thing to say also, these are slightly lagging both in the controls and the data you've got. So Rachel referred to the additional agency controls that TME approved towards the end of May. We'd actually begun to operationalise some of that approach before that, and that's why the agency costs are continuing to fall here. So agency costs in May were 1.1 million, and that compares to an average in Q4 in the region of about 1.7 million. And I think and if you look at in the pack, that's about half what agency costs were this time last year, and they're continuing to fall. We have also got recruitment controls, which have been refreshed to continue allowing to the divisions to hire almost without limit the more junior frontline clinical roles that end up getting substituted for temporary staffing if we don't have them, but have tightened the controls on all the non-clinical posts and the more expensive clinical posts. They're all essentially scrutinised by the execs every Tuesday. We rolled out a new.
So Jason, I'm just conscious of time. I think in relation to that, it would be good for us to have a chance to have a brief on it. We can decide whether
the one thing I was going to say is the point about recruitment controls is with notice periods, they're quite a lagging indicator. So there isn't actually a brief that we can really give for a month or two. You can see that pay costs have stabilised, but actually it will take a while for the controls over recruitment to show up in the pay bill, in the substantive pay bill.
So I think what we need is a sort of mark on the graph that says we've done these things, we expect to see them having an impact at this point, so that we can have a timely discussion of whether they are impactful or not. So perhaps with Paula's help, we'd take offline how we create that possibility, and we'll also take offline today the point that Katie's put in the chat, which is we had intended to have a look at the IT spend properly, and then we went into lockdown, and we need a discussion with David about when and how we do that effectively. And then I have Sarah Gordon.
Yeah, sorry, Jason, just page 61, just it follows on from your comment about the staff and that the costs aren't dropping in accordance with activity. On page 61, there's a comment that says that where substantive staff have been redeployed to other divisions because of COVID, their costs remain in their home division. And I just wondered whether that might be influencing this point about the level of activity, because if the cost is staying in the home division where activity has fallen, then it could be part of your question.
Sarah, it makes it very hard to do a really sort of forensic analysis at a service level, but obviously trust-wide you can look at total staffing and total activity. So the point is robust at a trust-wide level, but it gets it's harder to do that analysis robustly at a service or directorate level, because during the peak staff were moved around very frequently. But it's absolutely the case trust-wide that staffing has fallen by significantly less than activity.
So I think Sarah's point is, without that bit of analysis of where costs and where costs are accounted for, we can't tell whether we're making appropriate responses. Have I understood that, Sarah?
It is. I mean, I think Jason's point is at a global level, activity hasn't fallen as much as, or staffing hasn't fallen in line with activity. I think my point is that if you can't understand the detail of where the activity is happening, it's very difficult to get hold of where the problem is and deal with it.
Correct. If we had a small mismatch, if we had a I don't know, a 6% reduction in activity and a 3% reduction in temporary staff, for example, then you could say that it was all entirely going to be lost in the roundings of a slightly inflexible sort of staffing model. But we are basically looking at the areas we can identify. I mean, there's particular rotas or areas where we can see it, and it's just a harder task, Sarah. It's harder than sort of simply being able to run some analysis and pinpoint exactly where to look at. But we can look at it more than you might think, but not quite so analytically.
Okay.
So right. Sarah, can I invite you and Jason to have a little email exchange
yes.
on that? Not today necessarily, but over the next week or two, and sort of let me know what you think is the best way of getting a sight line on that, because it clearly is. We can understand the headline level, but understanding how we can do something useful to support colleagues about that, it's a bit more difficult. I'm taking it the cat's a substantive, not an agency cat.
Definitely a substantive.
Thank you. I think it's time for our break. So the video, which I would like everyone to try and watch, is 15 minutes. If we say that we reconvene by 20 past, which gives you time to get a cup of coffee, watch the video. But if everyone is back on at 15:15, then I will start the meeting. If you're back on before 15:15, I shall assume that you've already watched the video like I did early on this morning, or seen it in production. But we'll aim to pick up the business promptly at 11, and I will invite quite a lot of the items for the last part to be taken on an exception basis. That's to say, rather than inviting people to introduce the TME report, the safeguarding annual report, the RMO appraisal and consultant appointments, I'm just going to say, has anybody got any questions? I'm assuming that we do want to talk briefly about the others, but if the people leading on that don't feel that they have anything they need to say, they could perhaps let me know when we reconvene, and we'll try and catch up at a time from that, so that we do allow people to have some lunch before we restart in the afternoon. So see everybody by 11:20. Thanks very much, everyone.